A very good evening, ladies and gentlemen. A warm welcome to all of you to our sessions of Academic Hour Continuing Professional Development lecture series organized by the Clinical Society of Base Hospital Mahiyanganaya along with the Branch Union of Government Medical Officers Association. I'm Tavishi and I will be your host for tonight. Today, our topic will be on advanced trauma life support. Our keynote speaker for today is Dr. Jayasingha, consultant surgeon at Base Hospital Mahiyanganaya. So without further ado, let me call upon Dr. Senal Madagedara, consultant surgeon, to introduce our speaker for the day. Over to you, sir.
A very good evening for all of you. It's my pleasure to introduce my co-surgeon, Dr. Jayasingha, for today's lecture, organized by Mahiyanganaya Clinical Society. So, Dr. Jayasingha obtained his MBBS from University of Ruhuna in year 2008, and then he obtained his MD surgery from University of Colombo in 2021. And then the MRCS from the Royal College of Physicians and Surgeons in Glasgow in 2021, followed by the Fellowship of Minimal Access Surgeons in Association of Minimal Access Surgeons in India in 2022. After obtaining his MD surgery, then he has worked as a consultant surgeon at North Colombo Hospital, Colombo North Hospital in, and then National Hospital Kandy, followed at Teaching Hospital Gampala, and now he is working at Mahiyanganaya as the consultant surgeon. So, without further delay, I would like to invite Dr. Jayasingha to deliver his lecture on advanced trauma life support, which is a very important topic for all of the medical personnel. Over to you, Dr. Jayasingha.
Good evening. Good evening, ladies and gentlemen. Thank you for the introduction. Right. Today, our lecture is Advanced Trauma Life Support. So this is very important because when we look at the background of trauma, the WHO reports more than 9 deaths per minute in worldwide. So in annually there are more than 5 million people died. When we regarding our Sri Lankan values, there are 3,000 people died annually. So in 2021, statistics shows about 8 deaths per day. So now it rose up to 9. So this is my overview. Initial assessment of and management mainly target for primary survey and secondary survey. In this lecture, airway and ventilation management, shock assessment and management, and the patient is transferred to the definitive care. In initial assessment and management, so we have to follow the ABCD, the primary survey. So in that primary survey, our main target is identify the life-threatening conditions and treat. So there are mainly these life-threatening problems associated with chest and heart and chest. So the next thing is adjuncts of primary survey and resuscitation, consideration of uh, the needs of patient transfer and secondary survey, and adjuncts of the secondary survey. Then we have to think about the definitive care of patient. When we talk about the primary survey, the immediate resuscitation of the patient with life-threatening injuries. So we have to follow this drill. So always keep in mind, you have to go with the ABCD order. Why? Because that is the sequence. The patient can die. So airway is the first priority. So airway management, we have to prevent the hypoxia. So first thing is we have to, when you reach the patient, you have to assess the patient's consciousness level. Whether the patient can talk, the verbally responding, you don't worry. But you have to make sure that airway is patent. So when we talk about the airway and oxygenation assessment, we usually rely on pulse oximeter oxygen saturation. But when we consider the saturation, arterial blood gases and the pulse oximeter, that arterial blood gas level 90, it demonstrates saturation about 100. But we are bothering about the deterioration of the saturation. But at that time, arterial oxygenation dropped up to say 60. So you have minimum time to correct the airway and the saturation. So in this airway management, that identification of the problem, and we have to assess the airway difficulties. What are the circumstances you might get difficult airway? So airway maintenance and the techniques, definitive airway procedures, you have to think. So when we talk about the problem recognitions, failure to adequate access the airway. That means when the patient comes with the facial trauma, it's very difficult. So sometimes patient might come with the subtle changes you might not recognize at the initial state. So other thing is inability to establish the airway. Sometimes inadequate experience, inadequate instrument, and our laryngoscopes are not working properly. Our suction tubes and apparatus are not working properly. It might difficult initial assessment and management. So when you are struggling in correct the airway, so you have to think about the next step. So you can't waste. If the airway is obstructed, we have to think about the lung reserves. So in that lung reserves, it can give, we have only few minutes, few seconds. We don't have time to lose, right? Then we have to consider about we can't panic. We have to think about the other alternative techniques to establish the airway. So other thing is, even though if you put the proper endotracheal intubation, even though you put the definitive airway, the patient might deteriorate. in that case, you have to think what happened. You have to again go back and assess the airway. Sometimes when you intubation, there might be clots in the trachea. So you have to suck out the secretion. Sometimes you have to suck out the tracheal tube even. Right. Other thing is displacement. So if there's a failure to airway, you have to go for the second steps for the airway. So when we talk about the obstruction, the obstructive, you have to go with the signs, obstructive signs of airway. So one thing is agitated. The most of the patients come to you, you are ETU, so patients are agitated. But we have to think, we can't deny. It might be a pain. It might be a incidental related excitement. But so agitated as a medical person, we have to think about hypoxia. So other thing is obtunded. So we can't wait until the patient cyanosis. The cyanosis is last step. If the cyanosis is obvious, the next step is patient will arrest. So if a patient comes to you with noisy breathing, so you have to think about the upper airway obstruction. So snoring, stridor, everything comes to that. Hoarseness and subcutaneous emphysema and any palpable upper airway fractures. Sometimes you can't feel that subtle changes, engorged neck veins and other swellings, neck injuries. That can cause, that means threatening, that means compromise upper airway. So other thing is to evaluate the patient's behavior. Sometimes you might think this might be the intoxication, but intoxications you can't think initially. You have to think about the hypoxemia. Right? So in the airway maintenance, so you have to do simple maneuvers. Right? If there's no maxillofacial trauma, it's easy. But with the injuries and the trauma, you can't clear the upper airway properly. But when the patient comes to you, without any delay, you have to establish the secure the upper airway with the cervical spine, because you don't know about the cervical spine, spinal injuries. So you can do just jaw thrust and the chin lift, stabilizing the cervical spine. And then you clear the airway, and you can think about, if the patient is conscious level is low, you can think about the oropharyngeal airway and other options, laryngeal mask and the intubating laryngeal mask. So then the next step is you have to think about the definitive airway. You can you can attempt the definitive airway with the help of other instruments. The most experienced person has to do that. Right? Sometimes you can't do it alone. You need others' help as a team. So in the trauma management, we need the, usually most of the peripheral units, they have only doctor and the nurses. In that case, it's very difficult to manage the airway separately and the other IV access and the other management, and control the head even, right? So definitive airway management, if you can't fail the endotracheal intubation, sometimes we can do even nasotracheal intubation. If you fail, you have to think about, without any delay, when there are a lot of road traffic accidents come with motorbike collisions and fallen from motorbikes. So some patients coming with the full helmet.
It takes at least 2 people to remove a helmet from a patient while maintaining the patient's head.
Full face helmet. So in that case, we have to think about the how to remove the full face helmet. So in that case, initially we have to remove the upper visor. Then one person attend to secure the cervical spine. Then only carefully the person coming to the head end has to separate the helmet laterally and release the ear level, and gently lift it, tilt and take it out. You just observe. Otherwise, most of the time they are struggling with removal of helmet. Full face helmet is the difficult one. So the person who stabilize the cervical spine, while he stabilize the cervical spine, other one has to remove the helmet. Then only he has to secure the C-spine. So these are the laryngeal mask airway. So we can't see, right? This intubating laryngeal airway, usually we can't see this type of devices in our hospital. So this is the needle cricothyroidotomy. Very simple. You have to go with the proper anatomy and palpate the thyroid cartilage. Then just below, everyone know that cricoid cartilage, in between midline you have to insert the needle. So you can, the direction is midline 45 degrees downward, because that just above you feel that vocal cords are there. So in this case, you can't ventilate continuously, but you can give intermittent pulses. So this is the surgical cricothyroidotomy. This is the cadaveric demonstration. So when you identify the landmark, you have to put the midline incision. In this procedure, he is using bougie guided railroading, right? So next step is the management of oxygenation and ventilation. So in this oxygen and ventilation, we have to identify the problems, and we have to go with the signs of inadequate ventilation. So in airway obstruction, we have to think about these steps, right? Initially, altered ventilatory mechanics. The patient might having this chest trauma, chest pain. Sometimes he might presented with rapid shallow breathing. Sometimes you might fail to recognize fluid chest even. So other thing is CNS depression. Sometimes they might associate it with traumatic brain injury. They might associate it with intoxication. So in that case, you have to think first, always go with A, because hypoxemia can cause the altered conscious level. In that case, always you have to make sure the patient's airway is okay, right? Right. In signs of inadequate ventilation, you can go with the your clinical examination. Always examine the chest and chest movement, symmetry, and listen to the patient's breathing. And decrease and absent breath sounds mean you have to think about the life-threatening conditions. In that case, without any delay, you have to intervention of this tension pneumothorax, massive hemothorax or flail chest. In failure of recognition of inadequate ventilation, patient might rapidly deteriorate and arrest. In that case, so in observation, initially the patient's respiratory rate is very important, and work of breathing we have to assess. Other things is we have to go with ABG, assess the ABG and check the ventilation, oxygenation and the level of shock, and perform continuous capnography. That is ideally, sometimes we don't have. The next part is most important as airway and breathing, the circulation. In circulatory management, principle is when we talk about the trauma patients, we call there are 5 sites, one on the floor and 4 other sites. So chest, abdomen, we call separately pelvis and long bone fractures. So assess the circulatory volume status. We have to do it few seconds. So level of consciousness is, it indirectly called that cerebral perfusion, and skin color and pulse, rapid ready pulse cause the shock. That hemorrhagic control is the main target in our surgical aspect. If the patient is deteriorating, we always go back and assess the A and B. So if there's an external breathing, so we can do apply the direct pressure and compressive dressing. Even we can do sometimes wound packing. But careful, wound packing has to be done by the surgical team. Sometimes you might damage, further damage of the neurovascular bundles. Other thing is the tourniquet. Even it might be an improvised device, or simply we can use our BP apparatus cuff. So internal bleeding assessment, we have some other supportive agents. In that case, other than the physical examination, we have to go with fast examination. Even though it mentioned diagnostic peritoneal lavage, now fast can replace the diagnostic peritoneal lavage. In definitive bleeding management, we need IV access. Initial IV access and crystalloid, resuscitate with crystalloid. We can go with 1 liter of crystalloid resuscitation, and depending on the shock status, we have to think about the blood transfusion. So in this management, we have to think about the patient's lethal trial. So hypothermia, acidosis and coagulopathy. It all come together in a spiral manner, deteriorating the patient's condition. So, when you give IV fluid resuscitation, you can't do over resuscitation, because if you do more than 1 liter, it can it cause for coagulopathy, acidosis, directly cause the acidosis. The common question I asked from our even house officers, sometimes they don't know, because even our resuscitation fluid, normal saline, they don't know even normal saline's pH. It's also acidotic solution. When you rapidly infuse normal saline, it can cause hypothermia and acidosis. Well, then we have to think about the blood transfusion. We can't go with the normal saline. We have to think about the blood transfusion, depending on the shock. Mainly, we decide which type of blood transfusion we are going for. Sometimes we request group specific, sometimes we request O negative, or sometimes we activate massive transfusion on admission. Other thing of blood hemorrhagic control, we have to use for tranexamic acid. So even CRASH 2 trial, it accepted tranexamic acid. We have to give within first 3 hours of initial trauma. So if you fail to get the IV access, you have to think about the intraosseous access. So, right, there are a lot of things, right? But we don't have this much of, intraosseous. There's a special needle, and we have to use this power drill. Otherwise, we can't use intraosseous drilling at the ETU level. Right. So these are the potential spaces we can think about the internal hemorrhage. The chest, abdomen, pelvis, retroperitoneum, and long bones, extremities. Other thing, when we consider the hemorrhagic control, we have to apply the pelvic binder. So correct method of pelvic binding application is a simple thing. We can use as an improvised device. Just take the even bed seat and do the pelvic binding. So you have to think about the greater trochanter, that level. It directly we can apply the pressure to the acetabulum, which prevent the pelvic bleeding. So there are many times I saw at this hospital, lot of patients are coming with improper application of this pelvic binder, because most of the time they might apply minor stuff. Sometimes nurses are they don't know how to apply it properly. Right. So the initial fluid response, when we think about the responders, initial resuscitation response, there are 3 categories: rapid response, and transient response, and minimal or non-responders. So in rapid responders, we have to think about that their level of shock, that means class one hemorrhage, less than 15%. So other thing is they are bleeding inside or outside. That bleeding tendency is low. They might continuously bleeding, but at that time their bleeding is minimal. So we can wait and see. Other patients are transient responders. So in that case, we have to think about the patient might deteriorating rapidly next time. So we have to keep on eye. Continuous monitoring is mandatory. The minimal responders, non-responders, we directly take into the theater for surgically control the hemorrhage. So when we talk about the hemorrhagic shock, so hemorrhagic shock is a type of hypolimic. So there are many types of shock. So when we talk about the principles of this shock, there are 4 categories: hypolimic, obstructive, cardiogenic, and distributive. When we consider the former, the hypolimic shock is only problem is hemorrhagic. So always keep in mind, when the patient comes to your ETU, always patient having a shock status, hemorrhagic shock you have to exclude. Other than that, you have to think about the obstructive type of shocks. Depending on the mechanism and the injury pattern, you have to think about the cardiac tamponade, tension pneumothorax, and even neck patient coming with the neck injuries, you have to think about the air embolism. Other than that, all the other injuries are excluded. There's no hemorrhagic, but patient might have a cardiogenic shock because of myocardial contusion. They don't have other injuries, but you have to think about that. Distributive shocks patient can develop because of the spinal injuries. Even central cord syndrome, they don't have much changes in x-rays, but clinical signs are there. So this is the most important thing when you talk about the hemorrhagic shock. So you should know how to assess the level of hemorrhagic shock. So there are 4 classes. So most of the difficult managing part is class 3 and class 4. At there, the patient's blood pressure drops. Otherwise, blood pressure is normal. Only subtle changes are impending threat is tachycardia. So in class 3 and class 4 hemorrhagic shock, we have to think about the stop the bleeding, arrest the bleeding. It might be surgical intervention urgent. So we have to take the patient to theater. Right. So in disability neurological evaluation, even though patients having a cerebral perfusion, so traumatic brain injury might be there, but always think about the patient might having a hypoxemia or shock status. In that case, always go with A, B, and C again. You re-evaluate it and make sure the patient's A, B, and C is okay. Then only you have to think about the neurological assessment. So last part, the final part is exposure. So in that case, you have to examine spine, all extremities, but keep in mind you have to prevent the hypothermia. If the patient develop hypothermia, it aggravates the coagulation. So when you finish your primary survey, you have to do the log rolling. This is the proper way you have to do log rolling. At least you should have 3. assistance for the turn, and the examiner has to do the spinal assessment, and ultimately he has to perform the rectal examination. But this video digital rectal examination is not doing. They didn't do the digital rectal examination, but you have to perform digital rectal examination to assess the spinal, to exclude the spinal injury. If rectal anal tone is low, it's a first sign of spinal injury. So there are some adjuncts to assess the primary survey. So continuous monitoring of ECG is one part. Sometimes patient might develop arrhythmia. So pulse oximeter is mandatory, but we can't rely because patient even saturation is high. That means above 90. We can't predict the ventilation and the oxygenation of the airway, oxygenation of this lungs, and saturation of arterial saturation of oxygen. So other thing is entitled CO2, but patient with definitive airway we can do, otherwise it's very difficult. Other thing is ABG and VBG. We have to assess the blood gases and lactate level. So urinary catheterization is mandatory because of resuscitation, but at initial resuscitation you have to think about the airway, breathing and circulation. So NGO OG, orogastric tube insertion, you can assess the upper airway as well as the upper GI assessment. Sometimes patient might even you decompress the gastric distension. Sometimes blood might come out. It means some sort of facial trauma, and patient might swallow the blood. Chest X-ray, pelvic X-ray, and the focus assessment of sonography. So fast study is mandatory. We can exclude the abdominal, chest, and E-fast we can exclude other chest and the pericardium. So you have to start the secondary survey after ABCDE assessment. That means primary survey. So in this secondary survey, you have to think about the head to toe evaluation. So and complete the patient's ample history. Right. In the secondary survey, you can consider other investigations. So if the patient is stable in initial resuscitation, you have to think about the other investigation like CT, angiography, or other diagnostic procedures. If a patient is suspicious of upper airway or tracheal injury, sometimes patient might having surgical emphysema at neck level. So sometimes it's difficult to put the upper airway. Sometimes you might need video laryngoscopy and endoscopy, bronchoscopy. So that recording and recording is very important in our legal issues. So documentation is very important. In that case, you have to, sometimes you can't do it while resuscitation. You have to do it after the resuscitation. If there's sometimes we don't have doctors. In that case, you have to document what are the steps you have done for this patient. Consent for the treatment. Sometimes these are surgical emergencies, life-threatening emergencies. You can resuscitate. You can decide you can do the best interest of your management, right? So there's no there's no restriction to take the action. You can manage. So as a team, uh, there should be a team leader. Usually in trauma, uh, it should be overtaken by surgeons. Sometimes anesthetist might or intensivist might take the leadership. So airway managing uh, doctor and nurses, sometimes trauma technician and other residents should be there. Mm, the next step is when the patient is stabilized, you adequately resuscitate the patient, you have to think about the definitive management. In that case, we have to communicate with the receiving end team. Initially, the patient might resuscitate at ETU. Before you hand over to surgical ward or theater, you have to communicate well. So in that case, Mr. and SBA is the good communicating tools we have. So this is the last slide. So in our initial resuscitation, we have to go with the primary survey and secondary survey. So always think about the airway, breathing, circulation and steps. You can't, even though you see the hemorrhage, you just put the gauze pack and apply the bandage. You have to think about the airway. Airway first. Airway, breathing and circulation. While you are resuscitation, if the patient is deteriorating, you have to go again airway and breathing and reassess. Right? Other thing is what we have to do our shock management. Sometimes you might miss initial subtle changes. Sometimes you might think the tachycardia is only pain, but you have to give adequate pain relief. You have to give adequate pain relief and see. Sometimes you might reluctant to give adequate pain relief. It's very difficult to assess the patient's GCS level. No, you have to give adequate pain relief, right? And we have to think about how to hand over our patients to next step, next management, either ward or either theater. Sometimes we have to transfer the patient straight away from the ETU to other hospital, definitive care centers. Right. When we talk about this ATLS protocols, the day-to-day what we face at the base hospital Mahiyanganaya. As a team, when the patients comes to ETU, as a team, they attempted initial resuscitation, they start and inform to our SHOs. Sometimes their decision making might be delayed. Without any decision delay, we have to go for their management. Sometimes they might wait our decision whether the patient is going to intubate. I think it should, we can't wait others' opinion. If they have to follow the instruction, that means guideline. The ARV is not, they can't manage airway, so go with proper definitive airway. Right? We can't delay. Right? Other thing is communication. So communication is other challenging part. Sometimes it might be a 10 to 15 minutes delay, but patient might having detrimental effect for the patient's hypoxemia. Sometimes patient might having a hypoxic brain injury. So we can't reverse. Other thing is everyone knows we don't have adequate equipment and monitoring. Our pulse oximeters are not working properly. Sometimes we don't have capnography. Sometimes we can't, when we ordered fast scan, sometimes we don't have fast scan. We don't have scanner. Sometimes that scan machine taken from the radiology department. So these are the challenges we have. Right. Thanks for everyone to coming for this session. Right. Thank you. Are there any questions regarding the primary survey and secondary survey? I mainly targeted for our ETUs, ETUMOs, and our HOs. Sometimes they are not detecting initial subtle changes. They don't think about even tachypnea, tachycardia. Those are subtle changes. Even agitated patients, they might think this is due to pain. No, this is due to, we have to go with the basic principles. So when we talking about the trauma, there's a saying, there is only golden hour. That means golden hour is when everyone knows, when sun is sunsetting time, few seconds we have, few minutes we have. The environment is changing. So we should know that sign. The patient has activated his death race. So we have to stop the death race. It might be airway, it might be breathing and ventilation, it might be circulation. So we have to control. Those are the main 3 steps we have to control. We have few. Airway we have few seconds, few minutes, airway and breathing. But circulation we have few minutes, more than that airway. Right, we have to think about that. Any questions?
They start on inotrope. You thought about inotropes in primary survey.
Yeah, inotropes has a place, but you have to make sure you have to fill up the intravascular compartment. You have to follow the things. First you have to, sometimes, as you said, they have started inotropes.
Thank you, madam, and thank you, sir. A kind reminder for all of you to join us in exploring this wealth of knowledge and resources available on the Mahiyanganaya Clinical Society's blog. You can also access the videos of our academic sessions and even the national guidelines to keep you updated all on one platform. So the website details will be displayed on the screen for your reference. And a kind reminder to fill the feedback form for today's session as well. And without any further delay, on behalf of the Clinical Society, I would like to extend our sincere gratitude to our speaker, Dr. Jayasingha, and also the members of our surgical unit, GMOA Branch Union, and our main sponsors for today, Sun Pharma, Searle Company, and Sterling Lab. Thank you very much for making our event successful. The next session on our lecture series will be on the 2nd week of October by Dr. Punhasi Vaduge. And a kind reminder as well, to please collect your certificates from your unit representative before you leave today. And please fill your feedback form as well. So thank you very much for everyone for joining tonight. Enjoy the rest of the evening. Good night.